Welcome everyone to Assisi Animal Health's CE. Today is erase approved, and the subject matter is perioperative analgesia. What are the options for opioid-sparing relief? Our presenter today is Dr. Jennifer Johnson. Dr. Johnson has been a small animal veterinarian for 27 years, owning and operating a busy practice in Philadelphia's suburbs. Focusing on pain management early in her career, Dr. Johnson achieved CV pain practitioner qualifications from the International Veterinary Academy of Pain Management, IVAPAM to the rest of us, and speaks nationally, teaching the importance of multimodal analgesia in veterinary medicine. Now located in the foothills of Arizona, Jennifer is current president of IVAPAM, and she also serves on the board of Vigili Condor, providing medical and surgical care for animals in Ecuador. We welcome Dr. Johnson.
Thank you. Thank you so much. I'm so glad everybody is here today for a little bit of lunchtime learning. And thank you to Assisi for asking me to participate in these webinars. They've been great. I do want to take a minute to make a little plug for the International Veterinary Academy of Pain Management. If you are not familiar, please go on to our website, ivapm.org, and learn about us and our mission to educate about animal pain awareness. So today we have a short period of time for a big topic, and I thought that our journey today should entail a couple things, not just about opioids, but why do we care so much? Why do we care about pain so much? What does this opioid crisis you hear about, the problem with getting opioids, the problem with opioid diversion, what does it mean to veterinarians, and some opioid sparing solutions that I think will be quite valuable for you. So why do we care about pain so much? I think this is step one. We care about uncontrolled pain. We like pain in certain instances, but we really care about uncontrolled pain for a variety of reasons. It compromises our immune function, it slows our patient's healing, it can increase our morbidity and mortality after surgery, it can promote cancer growth, and actually create changes in our motor function over time. Uncontrolled pain is a bad thing. And pain has really diverse etiologies, mechanisms, characteristics, and it can cause a variable response that's interpreted differently among individuals. There's so many genetic variations that influence our baseline pain sensitivity, and the likelihood of us developing chronic pain has been noted and is continued to be studied, especially in humans. There are so many multiple factors to address. Fink tells us to think of pain as this tower of cards, where the bottom layer is environmental and those psychological and social factors, and then we go to genetic factors and the variations that individuals have in the transmission of these signals, and then the response that the pain transmission produces, and then up the top is the reaction with this system that's gone crazy, and that's where we have the result of chronic pain. And then up top at the very point is how clinicians, nurses, and doctors interpret a patient's pain, and then the very, very top is the treatment of pain. All of that is contingent upon understanding that tower below it, and treatment of pain will be limited if we don't understand it, limited or non-existent at best. So we have to think about the basic pain cycle and look at what physiologic pain is and how we can develop into chronic pain. The idea that physiological pain is our early warning system is pretty simple for most people to realize. Ouch, I burned myself. Ooh, that hurts. When my hip moves around and I'm running up the steps and I'm too old to do that anymore. It's that mechanical, thermal, or that stimulation of nociceptors, which creates a reaction and goes through that normal nociceptive pathway. It activates a withdrawal reflex. If I touch the stove, or if I take my really bad knee and run around on the weekend playing basketball, it activates that withdrawal reflex, makes me start to limp. So that's kind of that normal warning system. Hey, don't do this anymore. But what happens with pathologic pain? Pathologic pain is that response to continued tissue injury or inflammation. It follows the same pathway, but it differs from that warning system pain because it's initiated by persistent tissue injury or inflammation. I think of it, and I hope you remember this, I think of things really simply, is that all of a sudden we're using a delta A beta fibers, and now we're waking up those C fibers. Hello, we have this sensitization, which is basically an amplification of the pain response. But there's an important concept to this. We can't look at this pathway as being two-dimensional, up and down. It's not just pain to the brain and back again. There's concurrent ascending and descending influences. And I kind of, again, look at this really simply as a symphony of neural activity. There's all kinds of things going on simultaneously in both directions. And this delicate balance, it's really when this delicate balance kind of tips in favor of the excitatory message, the excitatory nociceptive message that an individual experiences pain. And pain becomes less reflexive and more of an opinion that the body forms about its physical integrity, about overall how it feels. So that's why effective pain management is such a dilemma, because nociception isn't really pain. Pain is continually evolving, and the brain is just not a final compilation site of all of the messages that we get from our periphery, because the brain is plastic. And this chart that I'm showing, there's my little dog there, the one in the background, that's Van, and you'll see him in a couple other pictures, but I love when he was just a baby. But the idea, this chart is kind of a representation of the previous slide that kind of demonstrates all of those complex mechanisms that are involved in the development of chronic pain. The purple box on the top demonstrates that the most interesting aspect to me is all this, all of the multiple variables that are completely patient specific. So we have that central mechanism, that peripheral mechanism, and we have descending control, and it's going back and forth, but we also have all of these other factors that we have to take into consideration. If we are not successful in treating pain at first sight, there's a great potential for a patient to develop chronic pain. And how does this happen? It happens via the concept of neuroplasticity. So peripheral sensitization, which is really modulated by what happens with capillaries and mast cells and the nerve endings that contribute to this signaling, can lead to central sensitization. And that's where we talk about primary hyperalgesia, where the pain response is exaggerated, or secondary hyperalgesia, where we recruit nociceptors that haven't been involved in the normal response. And we also have allodynia or allodynia, however you like to pronounce it, non-noxious stimuli. So the idea that if I just touch you gently, I can activate a really severe pain response. This all leads to this central sensitization where we see membrane excitability and decreases in our protective mechanism of inhibition. And now we have that uncoupling of the pain response from the original peripheral stimulation. And that's why we are so concerned, especially in a perioperative fashion, because we have these factors that can develop into chronic pain. So looking at this simply and remembering what we see in our patients, what factors really influence our what we call our body self matrix, the way that we respond to pain. And I love to show these images because it's the redheads, right? The crazy, I mean, that picture on the right is certainly a crazy looking red husky. I even made it look crazier with the 2 different color eyes, right? And the redheaded child, that certainly, what's the difference between those individuals and the laid back golden retriever and Spicoli from Fast Times at Ridgemont High? The idea that factors that influence the body self matrix and the way that we respond to pain are related to genetics. Certainly genetics play a big part. We see there's enough evidence to suggest that there are genetic variables to the way that our patients will respond to pain. We also have to think about learned behavior, and some people will call this history or historical behavior. For example, the aversion study in calves, where the learned behavior after they did not have adequate analgesia when they had disbudding, it creates chronic pain phenomenon. And all the studies that they did in infants, human infants, when they were getting circumcised and not being provided with appropriate analgesia at circumcision, led to increased pain response at the time, but also increased pain response down the line when they received vaccination, or another painful stimuli created an attenuated response. So thinking about all these and the learned behavior, that neuroplasticity that can occur because of an inadequate control when we had an acute pain situation. And then we have to add the third influence that I think is really important, and you're going to see some other webinars on this. I think with the CC in this course, the idea that environmental influence or fear or anxiety can play a complete role in our long-term effect and the development of chronic pain. It has been quite studied, and studied even more so in people. The environmental factors are just beginning to be studied in our companion animals, but there's really good evidence when we look at human pain and that biopsychosocial model, where the influence of fear and anxiety and stress can have a significant impact on their experience of pain, and specifically chronic pain. And this is so important because all vertebrates have the same basic setup as far as neurons and this whole response. It's our cerebral cortex in higher vertebrates that's a little bit more evolved, but the idea that anxiety and fear and pain and stress is true for all vertebrates makes a lot of sense in current study. So here we go. All of these influences, and this slide is just there to take the time to say, okay, here we go. Dr. Jen's putting it all together. Over time, we have all these inputs to what happens in our neuromatrix and how our pain perception and our action and our stress regulation, and our patients as well, decides to take all that information, and the result effect of it and what we are able to manage as a pain response varies completely beyond among individuals. So what's the point? What's the point of me explaining all this and that depressing idea that if we're not very careful, we can really develop chronic pain phenomenon? Every day we're causing pain by performing painful procedures, or while we're attempting to alleviate pain by performing painful procedures, we have the potential to create this maladaptive outcome. Therefore, we must always be really alert and not reactive, because the point is how do we get from an acute pain to no pain? What are the keys to this? Or how do we take this maladaptive chronic pain changes that have occurred when we went from acute pain to chronic pain and get to that no pain? What are the keys? And I think that being alert, being preemptive, and being multimodal is the key. And this is really what is important to remember as we're looking at the journey from surgery to recover. And when we think about perioperative anesthesia and analgesia with a pain management focus, our main concern is that we need to think about multimodal, preemptive, and comprehensive pain management techniques for success. So why multimodal? So when we think about multimodal, and I like to use this slide to represent how we should perform perfect anesthesia and analgesia. You know, we need our patient to be unconscious, we need to use appropriate analgesia, and we need, especially in veterinary medicine, to use some type of sedation and muscle relaxation to perform this balanced anesthesia protocol. But we're not just thinking about anesthesia. And of course, looking at anesthesia in the 4 phases, pre-med, induction, maintenance, and recovery, helps us to create balance. What we're also thinking about is using analgesic strategies to make this balance and to make it most successful. And by using preemptive and multimodal and continuing in the post-operative, we'll have the best success for inhibiting the potential of creating a chronic pain situation. So that's where it all ties together. Remembering that by multimodal, we mean that we want to inhibit in all 4 sites of the pain pathway: transduction, transmission, modulation, and perception. So for example, we know that being able to alter more than one of those 4 nociceptive processes is associated with better pain relief. And we can reduce the dose of individual drugs. We can decrease the likelihood of potential side effects. And many times, if we are using multimodal analgesia, we can attenuate the response of the combination when we look at it compared to just using one modality in and of itself. So preemptive analgesia promoting better outcomes. This slide kind of represents a simple model and a review for you of the rationale of being preemptive. So multimodal, yes, but preemptive even better, because the idea that if we have an injury and we have some type of hypersensitivity that wakes up those C fibers, right? They recruit, and the potential for the sensitization that we don't want to see, we will have that. And potentially in what I would say a normal patient, or a patient that does not have the genetic and environmental and historical factors that may lead to prolonged hypersensitivity, it should disappear and go slowly down over time. If we provide an analgesic, we should be able to dampen that hypersensitivity response, but there is a potential to have it again elevate and then slowly disappear over time. And the length of this time is based on those factors that we just spoke about: the genetics, the history, the environment, and past treatment. If we're preemptive, we certainly can have the potential. We'll still have that acute injury reaction in some instances, possibly, but we have the potential to really decrease the hypersensitivity action completely and be able to have much better outcomes. Certainly, if we use pre-surgical epidural or local anesthetics or opioids, we can reduce the overall analgesic requirement and prevent, or even reduce, hopefully prevent, but certainly reduce central and peripheral sensitization. I like this. It's better to prevent pain than to treat it. We should always have that in the back of our minds. So I hope that just kind of is a quick 20-minute kind of review on why pain is so important and why we're so concerned about this, especially in the perioperative environment, because we always should be looking. I kind of grabbed your attention with the title of this webinar, opioid-sparing, but why is this such a concern? We really don't have, we have a lot of resources. I don't have time to to explain or talk to you about all the FDA resources, but they're there for you. I want to share with you, and after this webinar, you'll have a copy of a PDF of my slides so you can go back and look at this. But the FDA has taken a lot of time to provide us with resources on prescribing and overdose and monitoring for diversion and employee abuse and all of the things that we need to be very concerned about as regards to the opioid epidemic in certainly North America, the United States and Canada, and we're seeing it across the rest of the world as well. I have to tell you that it continues to be a big concern. You might have gotten this email. I got it from the FBI this week that our profession has usually been flying relatively under the radar when it comes to the potential for diversion and abuse of our products. But this notice was just emailed this week, and you may have gotten it, but the idea that there's so many vulnerabilities within veterinary medicine and the increased risk of criminal activity with regards to our pharmacy is one of the concerns with the opioid crisis. The other big concern is with availability. And we started to look at this in 2018, and one of the best resources regarding veterinary solutions was this white paper that was published by the Veterinary Opioid Task Force in 2018. It's available on the IVAPM website, and it attacks the issue of opioid supply and details all of the options that I'm going to go over and discuss. Couple this with what's going on with the COVID pandemic, and there is no better time to consider some options for your practice, especially because people have been really having issues with supply for veterinary medicine. We are kind of low on the totem pole as far as the opioids and the availability for our patients, so we need to look at other options. So let's do something, right? I love this picture. This is a patient that needs us to do something. We call this the wilted flower look, this poor baby, certainly. So let's evaluate your opioids, employ CRIs, take advantage of synergy, and consider some non-pharma options. These are the things that I think that you should kind of outline as your take-home message to your practice. So why do we need to evaluate our opioids that we're using right now? Opioids have their place, certainly. We've been very lucky in veterinary medicine because opioids, we use them primarily for perioperative acute use, augmenting issues with pain, and in a multimodal analgesia protocol. They have their place to acute use to prevent chronic. The idea for using opioids for chronic use in veterinary medicine has not really taken hold because first of the availability of opioids that are effective in our patients orally, but also for a good reason, because we knew, I always say veterinarians knew this long before they did on the human side, we know and we knew that it wasn't a great idea. They have their place to deal with acute conditions, but can be quite detrimental to use for chronic use. So I want to reevaluate your opioid options. When we're thinking about the opioid crisis and supply issues and diversion and regulatory issues, we should take a look at veterinary specific opioids, which you may not be using and may be really helpful for you. And I want to bring up Symbidol, or veterinary labeled butorphanol, and long-acting butorphanol. So the labeled dose is subcutaneous in cats at 0.24 milligrams per kilogram. And that's a nice 24, and some people say more, hour analgesic effect. And I think that that's great. I think that a lot of people have great success with this. I think that if I ask you, you probably will say, oh yeah, I've used it in cats and it's really beneficial. And this is a great way for me to be able to use a veterinary labeled product that isn't going to be as problematic with supply and diversion. But off-label, if you haven't looked at it, you can use it IM or IV, which is the same as the human buprenorphine that you're able to get at the same dose. 0.02 milligrams per kilogram will give you 6 hours of good analgesic effect. And it calculates 6 times cheaper per milligram than the human counterpart. So although buprenorphine on the human side has not shown to have such an issue with availability, because they use it specifically for addiction problems. They don't use it usually in the ER or the ICU. It's still something for you to think about as an option to be able to use something that's veterinary specific and veterinary labeled. So that's one of the thoughts that I have about you still going to an opioid. The other is butorphanol, and I can probably hear you hissing through the phone. Why does it have such a bad rap? In this study, meloxicam performed better than butorphanol postoperatively. It was pretty obvious. So everybody's like, butorphanol is not a great analgesic and not great opioid analgesic. But think about this. Let's take advantage of synergy. This is a really nice human study, but we know this with veterinary medicine as well, because many of you may be using this combination, that butorphanol alone, that in this study, they gave patients butorphanol alone or butorphanol with dexmedetomidine perioperatively, and then they did a patient-controlled CRI postoperatively after hysterectomy. The patients that had the combination used about 18% less butorphanol in the patient controlled. They had better pain scores, 24 hours, less nausea and vomiting, so less effects from the opioid, and no difference in sedation between the two groups. So looking at synergy with butorphanol, there's significant opioid sparing. Significant. So this is also an option that I think that most people aren't looking at. The oral opioids, we know about tramadol, that it just very small amount of the metabolite is opioid, and no other metabolite is at all. So that's kind of difficult. The codeine, hydromorphone, hydrocodone, oxycodone, all oral absorption of it, very variable. They did an interesting study published last year about with dogs that were taking oral methadone, which they thought was not absorbed well in dogs. But if they added fluconazole, that there was significant effects and some increase of the extent and duration of the effect of methadone, which is kind of interesting. But the idea that if you're going to use an opioid, that you have some other options as far as injectable makes some sense. How about CRIs? And this goes back to opioid sparing is the least amount that we want to use at once. Everybody loves, most of you love your fentanyl. It's an awesome drug for CRI. It's so easily titratable, but it's also the #1 favorite in human medicine. So supply may be a real issue. A great resource is the CRI calculator on the IVAPM website. You can go on and you can just click CRI calculator and pull it up, and it has wonderful doses and resources and notations about using combinations. So if you're having trouble sourcing fentanyl, or you have morphine and you don't have hydromorphone, and also the combinations are so important, because again, looking at synergy will allow us to be able to use less of the opioid as a single agent. Like I said, I know everybody loves fentanyl single agent, but there's great benefits with combining dexmedetomidine and ketamine and lidocaine and holding off on the opioid. Bringing up ketamine, I think this reference, it's in Gaynor and Muro's Handbook of Veterinary Pain Management. The deal with ketamine is that NMDA receptors are found in the dorsal horn of the spinal cord and some areas of the cortex. So if we have really intense C fiber stimulus of the dorsal horn, that causes magnesium to just be removed, which activates the NMDA receptor by glutamate. And once that's activated, it causes repeated firing of the spinal neurons. So basically that windup is all regulated there and leads to that central sensitization. And that's where ketamine is the jewel, because at low doses, it blocks that NMDA and also seems to also, this is also pretty awesome, it improves that mu receptor sensitivity, which can reduce opioid tolerance. So if you have a patient that's been on fentanyl for a really long time and you are reducing it and you are also adding ketamine, you can improve that opioid receptor sensitivity and minimize that rebound hyperalgesia that we can sometimes see when opioids are withdrawn. So ketamine's a great option. I like to bring this up even by itself, that you can do a quick CRI and be able to utilize this for opioid sparing. So lots of references here for CRIs. And then taking advantage of synergy and the idea that we can do multiple things at once, multimodal, be preemptive, but be multimodal. And there's so many options to take advantage of synergy. NSAIDs and blocks, you know, I put lidocaine in here, and the NOCITA. NOCITA has some great applications here for synergy and for opioid sparing. Amantadine, gabapentin, Serenia. I bring up Serenia because usually this is what people ask me, and in an hour, I mean, this lecture could be 5 hours, but in an hour, I always like to include, because people have a lot of questions about this, NK1 receptors, and they are found in organ tissue and in blood vessels. And so when we have excitability, the sensitized neurons take up substance P and continue on through the spinal cord and into the brain. And endorphins are released in the dorsal horn at the same time as substance P. And with the release of endorphins, substance P release is inhibited. So fewer pain impulses are sent to the brain, which is great. So meropenem blocks the release of substance P, preventing vomiting, but the NK1 receptors are found in organ tissue and blood vessels, which may be an adjunct. So they looked at this at Colorado State, where in 2011, I think, David Tweet, he looked at that meropenem decreased the anesthetic requirements during stimulation of the ovary and ovarian ligament in dogs. The results suggested that there's a potential role for NK1 receptor antagonists, and they did it again in cats in 2013. The big, I mean, and here are the studies about that. The big question is it really dealing, and they've looked at this in people too with NK1 receptors and substance P inhibition, but that we're not really sure. The point is that certainly the use of perioperative Serenia is well documented, because the idea that our patients feel better is certainly one of those psychological, biopsychosocial factors of pain, which I think cannot be ignored. That sense of well-being in surgical patients that are getting other medications that may make them feel lousy, in chronic patients, that chronic renal failure, chronic pancreatitis, triad disease, pyelonephritis, all these painful inflammatory conditions, the idea that we can provide this at a low dose and be able to make them feel better while not directly inhibiting pain could certainly be something to look for. And then I always bring up the alpha-2s because I'm a big dexmedetomidine fan, and it's funny to me, why are we afraid of this? Because there's so much good. as far as pain control, decreasing norepinephrine, reducing nociceptin, decreasing MAC, being an additive analgesic because there's a synergy with opioids and you can use it as an epidural, and synergy with local anesthesia. The thing that people don't like about it is the physiological effects, the scary effects, the cardiac output, the respiratory effects. I put what about cats, and the reason I put what about cats is the idea is that, yeah, it's the physiological effects we see a lot less often in cats, which is a good thing. I just remind people about what they use in humans, that it's used in the very young and the very old. They pick their cases, but the idea that using dexmedetomidine at low doses to be able to prevent the emergence deliriums and the agitation and be able to create an analgesic plane in combination is used often. And then in the old, in geriatric and end-stage renal patients, and in patients that are developing and need to be on ventilation, using dexmedetomidine is pretty routine. The idea that in humans that they looked at the efficacy and safety of adding dexmedetomidine to caudal bupivacaine in a local block showed that that they achieved significant postoperative pain relief for up to 19 hours with less use of postoperative analgesics, so completely opioid sparing, which is great news. Things like Amantadine, an NMDA receptor antagonist. I always look at this as the oral ketamine, the idea of utilizing it to be able to work on the NMDA receptors is a wonderful adjunct and opioid sparing device that can be utilized in our patients. And gabapentin, the dose dependent inhibition of the dorsal horn, decreasing allodynia related to that pressure. It's structurally similar to GABA, but it's not a great agonist, a direct agonist. It has an indirect effect on GABA metabolism, we think. It's TID administration is probably most successful if BID is not working. It's kind of difficult to sustain that, but the idea of having this wide dose range as well, starting out low and titrating to the effect that's necessary, and the limiting factor is sedation, which will be the most successful with gabapentin. I just want to bring up also about using it for that fear-free, a common use of gabapentin to reduce the anxiety, fear, and stress that can lead to wind-up, which can potentially lead to chronic pain phenomenon. So there's the synergy. Let's talk about the non-pharma options for the next 20 minutes. And I really, there's a lot of them, but I thought I would concentrate really on two, and looking at non-pharmacologic considerations for opioid sparing. The idea of using laser therapy has become pretty common. It sounds like, based on what photobiomodulation does, that laser therapy should be able to be opioid sparing, right? It creates this biochemical cellular response that causes analgesia. It acts as an anti-inflammatory, can actually repair tissue and help cells grow faster and better. And I would consider that suggest that considering using laser therapy perioperatively and postoperatively in place of warm therapy and cold therapy can be a great benefit, because it's a longer lasting benefit, because it creates these effects at a cellular level and can actually show a neurologic change that can reduce pain. And I show you, I have a slide sooner. Now, obviously, people are using it. This is my little Van Gogh and the injury that he had when somebody decided to cut his ears off with scissors. The idea of using photobiomodulation along with our multimodal analgesic protocol makes a lot of sense. So incision work and acute pain reduction in a faster fashion has been well documented and studied in veterinary medicine and in human medicine. It's interesting because this study, where they looked at people that were undergoing cardiac bypass surgery, so they had open heart surgery, they said, how easy would this be to be able to use therapy laser to help reduce the amount of opioids that our patients are requesting. So many times they have patient controlled analgesia with fentanyl, which is usually their rescue. They treat with tramadol and acetaminophen in people. And what they found that just by adding photobiomodulation, they were able to eliminate the need for rescue analgesia. And also some patients only required one postoperative treatment of the incision, and there was much better pain scores in the patients that received photobiomodulation. So really, so here's a good study to look at for people that still wonder about the documentation that goes along with these non-pharma options like laser and PEMF. Here's a good one that they just published. They looked at photobiomodulation implications for anesthesia and pain relief, exactly what we're talking about. And this is Roberta Chow. So she said that being able to utilize this, but really not knowing how it works was their goal. And what she found was that that photobiomodulation at a specific wavelength, at a specific dose, can inhibit translation of pain centrally via local conduction block. So neurologic changes that we will see because of this particular wavelength of light. So I think I'm just going to give you some examples. I look at things that people aren't always thinking about with laser therapy, like gastrointestinal pain and perioperative, like here we are in surgery with a very painful procedure, an anastomosis, resection and anastomosis, or an enterotomy. The idea of using it intraoperatively makes a lot of sense, because what are our goals? Increasing blood flow, reducing inflammation, hastening the wound healing, causing vasodilation to assist removal of those pro-inflammatory mediators that we don't want around there anyway. The idea of using it when we have inflammatory GI conditions in surgery to be able to reduce speed healing, reduce the need for post-operative opioids and overall pain control. And how about patients that have pain and are not here for surgery? So looking at pancreatitis or inflammatory bowel disease, big dog and cat problem that we see in practice. Our goals are reducing pain and inflammation, improving quality of life, modification of other drugs, like if we had to use opioids or other pain medications that they're taking orally or by injection, reducing the adverse effects of them, not having to give anti-inflammatories as well. So just using a dose that's appropriate, administering it daily or every other day in acute situation, or chronically being able to utilize it to reduce the time in between treatments as we're seeing progression and improvement. And there's some good documentation for this. This is a human study where they looked at chronic pancreatitis, and they were able to measure microcirculation of the pancreas compared to normal patients. And that was a really good way for them to determine if photobiomodulation was having an effect. And what they found was that they didn't change their med protocol, they just added this and were able to see greater improvement in the microcirculation of the pancreas via Doppler. They look at it with Doppler flow compared to the patients that just received drugs alone. And how about with IVDD, the idea of using laser therapy to improve recovery after disc disease surgery has been studied and now has become an accepted protocol in veterinary medicine after dorsal laminectomy. And another human thing where they use laser therapy so much for inflammation and pain, and even perioperatively, this is actually oral mucositis with people that have throat and neck cancer. So the idea that it enhances quality of life and state of the art, reduces the need for other pain medications, helps the patient get to eat sooner and gain weight and feel better, and reduces the inflammation in the mouth during radiation and chemotherapy for mouth and throat cancer. So there's great benefits to using photobiomodulation, and the idea that it's really easy to use. You can incorporate it in the hospital. It's really great to do that. Using it in this perioperative fashion makes a lot of sense because your patient's there. It doesn't really interfere with other patients. It can help to reduce oral medications. It can help to be opioid sparing. But the downside about it is we need our technicians or a doctor or a skilled operator to do this. We can't incorporate it into a bandage, but opioid sparing for sure, and being able to utilize it makes a lot of sense. And this brings me to the other opioid sparing non-pharma option is pulse electromagnetic field therapy. And I'm sure you knew that I was saving the best for last because the CC has sponsored this lecture, but the idea that clinical research, there's a lot, over 15 years of research in the human side, and in veterinary medicine, there's ongoing research with Cavalier King Charles Spaniels, with syringomyelia, osteoarthritis in cats, elbow osteoarthritis in dogs, all kinds of things going on, looking at pulse electromagnetic field therapy, specifically in animals. But in humans, tons of stuff. We know that it accelerates a reduction in pain and inflammation and wound healing. It can help patients regain pain perception, decreases the nerve injury biomarker levels, improves wound healing, and is shown to be opioid sparing. We don't have time to go through all the data and all the studies, but research in veterinary science, there's a great review article that looks at a lot of the research as to how and why this works. But targeted PEMF, specifically that particular microcurrent that we use, has been well characterized for accelerating the endogenous pathway and being able to have this response to treatment in injured tissues by increasing calcium calmodulin binding and increasing cyclic GMP, causing tissue regrowth and remodeling. Again, a big nitric oxide signaling, very similar to what laser therapy does, but in a different fashion, decreasing all the cytokine releases and the result, neovascularization, increasing bone healing, and improvement in patient. The nice thing about targeted PEMF is that there really isn't any downside. It doesn't interfere with other treatments. You can actually incorporate it in a bandage or wrap because we're not using light therapy. We're using a microcurrent of wavelength, so we don't have any interference that way. The misconception about it causing angiogenesis makes people worried about cancer, which is still a worry with photobiomodulation, but is not found to be a concern with using pulse electromagnetic field. So what we know about tumors and blood vessels in tumors are they're abnormal vessels. They're tortuous. They're not normal at all. And what we found is that especially because they've studied this extensively in human use of pulse electromagnetic field, because they're using it on mastectomy patients so often, so there's cancer, is that the PEMF will accelerate the anti-inflammatory process, causing the healthy growth of good new blood vessels and normal tissue regeneration. And when they look at a brain cancer model in rats, and they look at tumor growth, they found no changes in tumor growth. So being able to use it in our patients post-cancer or during cancer has shown to have no adverse effect. And there's no FDA contraindication for using it with cancer patients as well, which is great. So here's one of those tram flap breast reconstruction human studies. And what we found is that opioid sparing effect of pulse electromagnetic field. So these women had mastectomies, total mastectomies, and then had a tram flap. So they had reconstruction at the time. And in their bandage and in their recovery, there was a pulse electromagnetic field device placed and within their bandage, and they found that there was a significant reduction in those pro-inflammatory mediator interleukin and significant reduction in wound drainage and less narcotic or opioid use by the patient, which I think is really important. The last ones in animals that I think that are really important to look at are the two studies that CC was involved with looking at intervertebral disc disease surgery in dogs and using PEMF. This first one looked at that nerve factor, that plasma glial fibrillary acidic protein, GFAP. It's a spinal cord injury biomarker. So it's high when the spinal cord gets injured and it goes down as there's improvement. And what they found was there was a significant improvement and reduction in GFAP in patients that received the PEMF as opposed to patients that didn't. And also the patients that had PEMF treatments had a reduced extent of their spinal cord injury and enhanced proprioceptive placement, overall significant improvement at 6 weeks. And then this other study, again, in dogs that underwent dorsal laminectomy procedures, that they used PEMF therapy using the loop to about 50 dogs. And they were randomized, half getting none and half getting the real PEMF. And what they found was that the wounds healed faster, that there was statistically significant reduction in the use of opioids and post-operative pain medication, and no side effects at all, which is great news for opioid sparing. So the idea of being able to combine all of this information together makes a lot of sense. With targeted pulse electromagnetic field, it's really easy because it's easy to use. They're in the hospital. It's something that you can send home. It's much easier for clients to do than sometimes shove a pill down a patient's throat, especially when we're dealing with cats. You can treat a variety of areas. That treatment area on either side of the applicator has a lot of applications in patients, and you can see a variety of ways to use it. And also there are the newer pads, the Loop Lounge and the Loop Clinica, have the ability to create, instead of that elliptical area of treatment, they're able to treat further, and you're able to have the animal under in confinement in that area. The idea on the right-hand side, this whole idea of looking at opioid sparing post-surgically and redoing your pain assessment and using it as a multimodal fashion, and being able to eliminate or decrease the amount of oral analgesics that you need to use post-operatively. The chart will help you make decisions, and the basic decision tree of when and how to use our treatment and how we can start to create better analgesia for our patients in a very proactive fashion.